Hello everyone. So the topic is shoulder or glenohumeral joint, elbow joint, radioulnar joint and wrist joint, important joint of upper limb. First is shoulder or glenohumeral joint. So this is a type of synovial joint and it is multi-axial variety. It is based on the articulating surface, ball and socket type of synovial joint. And here we see the articulating surfaces of the shoulder joint. The proximal articulating surface is the glenoid cavity present on the scapula. It is pyriform shape, and here there is one fibrocartilaginous ribbon-like structure which is known as glenoidal labrum, and it is covered with the hyaline cartilage. Here this is the proximal articulating surface of the shoulder joint. The distal articulating surface, here you can see there is head of humerus which is hemispherical in shape, and this is also covered by hyaline cartilage. Now here if you see, the shoulder joint is a weak joint because the glenoid fossa or the glenoid cavity is too small and shallow to hold the head of the humerus in place. The head is 4 times size of the glenoid cavity, so structurally it is weak joint. So stability of the joint is inversely proportional to the range of movement or how much the mobility is there. The more mobility, the more range of movement, lesser will be the stability, and vice versa. Now coming to the ligament of joint, there is capsular ligament, glenohumeral ligament, glenoid labrum, coracohumeral ligament, transverse humeral ligament, and along with that there are 2 accessory ligament, coracoacromial ligament and coracoacromial arch. The first one is fibrous capsule or capsular ligament. It is loose fibrous covering, and the inner surface of this is lined with the synovial membrane. So this is fibrous capsule of the shoulder joint. Next one is glenohumeral ligament. So it is present in 3 band. There is superior band, there is middle band, and there is inferior band. So superior band of the glenohumeral ligament, middle band of the glenohumeral ligament, and inferior band of glenohumeral ligament. They strengthen the anterior part of the capsule and they are seen within the joint. Now you also can see here there is what are the attachment of the glenohumeral ligament. So these 3 bands are there, superior, middle and inferior band of the glenohumeral ligament. They are attached here to the glenoid labrum, and also they are attached here with the head of the humerus. Then there is transverse humeral ligament. This is transverse humeral ligament. This is stretching between the upper part of the bicipital groove, and it is present between greater and lesser tubercle of the humerus. The tendon of long head of biceps brachii passes deep to this ligament. So this is transverse humeral ligament. Then there is coracohumeral ligament. Coracohumeral ligament is here, it is stretches from the root of the coracoid process of the scapula to the greater tubercle of humerus. So you can see here, this is the coracohumeral ligament from the root of the coracoid process to the greater tubercle of the humerus, and it is strengthening the joint capsule from above. Then there is coracoacromial ligament. This coracoacromial ligament is triangular band which is protecting the superior aspect of the joint. It is present between the coracoid process and the acromial process of the scapula. Then there is coracoacromial arch. So this arch is separated from the supraspinatus muscle by subacromial bursa. So here is supraspinatus muscle, and here is coracoacromial arch, and here is subacromial bursa, and it is acting as a secondary socket for the joint. So subacromial bursa act as a secondary socket for the joint. It allows the lateral rotation of humerus when the arm is raised above. Okay, so this is coracoacromial arch. So the factors which provide stability to the joint, these are the following: rotator cuff, coracoacromial arch, long head of biceps tendon, and glenoid labrum. Then rotator cuff or Codman's musculotendinous cuff. So the laxity and weakness of the joint is compensated by this cuff. It is known as rotator cuff. It is derived from tendon of 4 muscle. We can remember as 6 muscle. There is supraspinatus, infraspinatus. Okay, and here we can see there is teres minor muscle and subscapularis muscle. So there is supraspinatus, there is subscapularis. You can see supraspinatus here, infraspinatus here, and there is teres minor. Now the rotator cuff muscle are attached in such a way so the expansion from these tendon will fuse with the capsule of the joint and it strengthening the capsule all around except inferiorly. You can see here inferiorly there is no support. So the dislocation of humerus is most commonly occurs in downward direction, or inferior dislocation is more common. So the factors providing the stability to the joint, coracoacromial arch, as we have seen here, it is acting as a secondary socket for the joint and it prevent the upward dislocation of the head of the humerus. And beneath the coracoacromial arch there is subacromial bursa. Then there is long head of biceps. It is intracapsular and this prevent upward displacement of the shoulder joint. Then there is glenoid labrum, which provide protection by deepening the shallow joint cavity. Then relation of the joint. So you can see the relation of the joint. Here are the anterior relation, posterior relation. These are the superior and inferior relation. You can see muscles are there. So there is supraspinatus muscle. Here is the deltoid muscle. Here are the posterior fibers of the deltoid. Here is pectoralis major, and here deep to the pectoralis major there is subscapularis, there is infraspinatus, there is teres minor, here is the long head of the triceps, here is the teres major, and there are bursa related to the joint. There is subacromial bursa, there is infraspinatus bursa, there is subscapular bursa. Apart from these there are vessels and nerves, there is axillary artery and vein, there is here the posterior circumflex artery, there is axillary nerve. The muscles, so muscles are located anteriorly, posteriorly, superiorly, inferiorly. Okay, so this is the deltoid muscles which is covering from superiorly, there is anteriorly also, posteriorly also, and some here you can see here. So this is the deltoid muscle which is covering here and superiorly, anteriorly and posteriorly and also laterally. So you can see again the relation of the joint. Then bursa related to the joint. So as we know already, there is subscapularis bursa deep to the subscapularis muscle. There is subacromial bursa which is deep to the subacromial arch. It is also known as subdeltoid bursa. There is infraspinatus bursa and there is the synovial sheath of the joint. The subacromial bursa is present here deep to the subacromial arch. It is present between the subacromial arch and the supraspinatus muscle. It is extending laterally between the deltoid and greater tubercle of the humerus. This is the location of subacromial bursa. It does not communicate with the joint, and this is the longest bursa in the body. It is acting as a secondary socket to allow lateral rotation of the humerus. Now, what are the different? Two more are there. There is subscapularis bursa and infraspinatus bursa. Subscapularis bursa is intervening between the tendon of subscapularis and fibrous capsule, and remember it is communicating with the joint cavity through an oval gap between the superior and middle band of the glenohumeral ligament. Then there is infraspinatus bursa. It is lying between the tendon of infraspinatus and posterolateral aspect of the joint, and sometime it may communicate with the joint cavity. So here the blood supply of the shoulder joint, you can see here the blood supply, these vessels are arising, arteries arising from the axillary artery, and the veins are draining into the axillary vein. So branches are anterior and posterior circumflex humeral artery, subscapular artery, and circumflex scapular artery, which is also known as subscapular artery. Then the nerve supply of the shoulder joint. So there is a twig from the lateral pectoral nerve, suprascapular nerve, axillary nerve, posterior division, and lower subscapular nerve. All these supply the shoulder joint. Here you can see anteriorly and superiorly, anteriorly, here it is inferiorly, and posteriorly the joint is supplied by these nerves. Now, movement of the joint. So around the transverse axis there is flexion and extension. Around the antero-posterior axis there is adduction and abduction. Along the longitudinal axis there is medial and lateral rotation, and combination of all the three axes, it is known as circumduction. When the movement is along a circle. Now, movement of the joint and the corresponding muscles which are producing those joints. So first one is flexion. For flexion, main muscle is pectoralis major and the clavicular part of the deltoid, and for flexion, accessory muscles are biceps brachii, coracobrachialis, and sternocostal head of pectoralis major. Extension, here main extensor is the posterior fibers of the deltoid and also latissimus dorsi, and accessory muscles are here teres major and long head of triceps. Then abduction, for initial 15 to 90 degree abduction there is deltoid, and initial 0 to 15 degree there is supraspinatus. Then accessory muscle serratus anterior from 90 degree to 180 degree, and also upper and lower fibers of trapezius. For adduction there is pectoralis major, that means the sternocostal part and also latissimus dorsi, and accessory muscle for adduction is teres major, coracobrachialis, short head of biceps and long head of triceps. For medial rotation, there is subscapularis is the main muscle, and accessory muscles includes pectoralis major, latissimus dorsi, deltoid, anterior fibers and teres major. And for lateral rotation, the posterior fibers of deltoid are the main muscle, and infraspinatus and teres minor are the accessory muscle. So mechanism of abduction, the total range of abduction is 180 degree. Movement takes place partly at the shoulder joint, partly at shoulder girdle, where there is forward rotation of scapula around the chest wall. So scapula humerus move in the ratio of 1:2 throughout the abduction. That is, for every 15 degree elevation, the humerus moves 10 degree and scapula moves 5 degree. So here is the mechanism of abduction. So what is glenohumeral rhythm? The rotation of scapula is facilitated by movement at the sternoclavicular and acromioclavicular joints. The abduction up to 90 degree occur at the glenohumeral joint. Abduction from 90 degree to 120 can occur only if the humerus is rotated laterally, and abduction from 120 degree to 180 degree can occur if the scapula rotate forwards on the chest wall. So for abduction, not only glenohumeral joint is involved, but there has to be lateral rotation of humerus, and there has to be forward rotation of the scapula for complete 180 degree abduction of the shoulder joint. So here if you see, the deltoid is the main abductor for 15 to 90 degree. The beginning of the abduction here is the supraspinatus 0 to 15 degree, but it is not clear, and scapula is rotated by combined action of trapezius and serratus anterior, responsible for the 90 degree to 180 degree abduction. Then applied anatomy of the shoulder joint. First one is dislocation of shoulder joint. It can be due to laxity of ligament, disproportionate articular surface, and usually occur when arm is abducted. In this position, head of humerus pressed against the capsular ligament mostly occurs inferiorly, and because of inferior dislocation, there is chances of injury to the axillary nerve. Then there is frozen shoulder. So frozen shoulder is pain and uniform limitation of all shoulder movements occur due to the shrinkage of the joint capsule. It is also known as adhesive capsulitis, seen in 40 to 60 years of age. Rotator cuff disorders that include calcific supraspinatus tendinitis, most common cause of shoulder pain. So here you can see the rotator cuff muscle. Cuff is commonly injured by repetitive use of upper limb above the horizontal level, for example throwing sports, swimming, weightlifting. So here chances of rotator cuff disorders are more common. So in the rotator cuff disorders, deposition of calcium in supraspinatus tendon is common. Calcium deposition irritates the overlying subacromial bursa, leading to subacromial bursitis. When the arm is abducted, inflamed bursa caught between the tendon and acromion impingement cause severe pain, and usually it is there in males after 50 years of age. Pain due to subacromial bursitis occur pressure over the deltoid below the acromion when the arm is adducted. However, when the arm is abducted, pressure over the same point causes no pain because the bursa disappears under the acromion. So this is known as a Dawburn's sign. Shoulder tip pain can occur because of irritation of peritoneum underlying the diaphragm, and because diaphragm is supplied by phrenic nerve C3, C4 and C5, and the same fiber out of this having the supraclavicular nerve which has the C3 and C4 fibers, and supraclavicular nerve also supply the shoulder joint. So that can be shoulder tip pain here, so because of these same fibers. Now, so after shoulder joint, here is elbow joint and radioulnar and wrist joint. First is elbow joint. Elbow joint is hinge type of synovial joint. The articulation is present between the trochlea and capitulum of humerus. You can see the trochlea, you can see the capitulum at the distal end of the humerus, and there is trochlear notch present on the ulna, and there is head of the you can see the trochlear notch and capitulum, and you can see the trochlear notch present on the ulna, and there is head of the radius. So these are the three articulating surface for the elbow joint. Fibrous capsule is completely encloses the wrist joint. Here anterior and posterior parts are thin and weak, but they are strengthened by collateral ligament on its sides, which are attached anteriorly to proximal margin of coronoid and radial fossa, and distally are attached to the margin of the trochlear notch, anterior border of the coronoid process, and annular ligament. Synovial membrane of the elbow joint lines the internal surface of the fibrous capsule, and there are two ligaments. There is a lateral ligament and medial ligament, or we can say lateral collateral ligament or radial collateral ligament, and medial collateral ligament or ulnar collateral ligament. The lateral collateral ligament or radial collateral ligament, you can see here, it is triangular band of which apex attached proximally to the lateral epicondyle of the humerus, and base is blending here with the annular ligament of the radius. So this is the radial collateral ligament or lateral ligament of the elbow joint. Then medial collateral ligament. So here is the medial collateral ligament, which is also known as ulnar collateral ligament. It composed of anterior and posterior band connected by weak oblique band. So here is the anterior and the posterior band of the ulnar collateral ligament. So apex is attached to the medial epicondyle of the humerus here, the anterior part is strong. Here you can see cord-like the anterior band of the ulnar collateral ligament, which is attached to the tubercle on the coronoid process of the ulna here. Then there is posterior band which is fan-like and it is attached to medial edge of the olecranon process. And ulnar nerve passes posterior to the medial epicondyle here, and it is closely related to the ulnar collateral ligament. So you can see here, this is the lateral ligament of elbow joint or ulnar collateral ligament. Relation of the elbow joint: anteriorly there is brachialis muscle, tendon of biceps, median nerve, brachial artery. All these are the content of the cubital fossa. Posteriorly there is triceps brachii, medially there is ulnar nerve, and laterally there is origin of the common extensor tendon, and there is supinator. Okay, so you can see the relation here. You can see here, this is the all the relation showing up to the elbow joint. Movement and muscles of the elbow joint. So elbow joint can be flexed or extended. So flexion can be by brachialis, which is main flexor, also brachioradialis muscle. Biceps brachii can flex in supinated forearm, and pronated teres do flexion during pronated forearm. Extensor, triceps brachii is the main extensor, and gravity and the anconeus also assist while the extension. And you can see the blood supply of the elbow joint. Here are the branches from the brachial artery, branches from the ulnar artery, branches from the radial artery, and all these are branches are forming anastomosis around the elbow joint. So there is superior ulnar collateral artery, there is inferior ulnar collateral artery, there is anterior and posterior ulnar recurrent artery, there is common interosseous artery, there is a recurrent interosseous artery is arising from common interosseous artery, there is a radial recurrent artery, there is a radial collateral artery. All these are forming anastomosis in front and behind the elbow joint. Elbow joint is supplied by median nerve, ulnar nerve, musculocutaneous nerve, and radial nerves. The carrying angle of the elbow joint. So here the carrying angle of the elbow joint is different in male and female. So, but there is no different functional capacity is there. Next one is radioulnar joint. So radioulnar joint are present between the radius and ulna. So at the proximal and distal end, the synovial joint are called proximal and distal radioulnar joint, and these are the pivot type of synovial joint. They produce pronation and supination. Proximal radioulnar joint. The proximal radioulnar joint is articulation is between the radial head with the radial notch on the ulna. Head of the radius is held in the position by strong annular ligament, and fibrous capsule is continuous with the fibrous capsule of the elbow joint. Again, the synovial membrane here is present on the deep surface of the annular ligament, and it is continuous above with the synovial membrane of the elbow joint. Ligament here is, apart from the fibrous capsule, there is annular ligament which is attached to the anterior and posterior margin of the radial notch, and it is continuous with the capsule of the elbow joint, but it is not attached to the radius. Nerve supply of proximal radioulnar joint. It is supplied by the branches of median nerve, ulnar nerve, musculocutaneous nerve, and radial nerve. Movements allowed are pronation and supination of the forearm. Relation: anteriorly there is supinator and radial nerve, posteriorly also supinator and common extensor tendon, medially ulnar nerve, laterally common extensor tendon and supinator. So here is the applied anatomy related with the proximal radioulnar joint. So this is the normal. Here there can be subclinical subluxation, there can be dislocation of the joint, and this is also example of subluxation. Then there is distal radioulnar joint. It is also type of pivot joint of synovial joint. Articulation is present between the head of the ulna and ulnar notch of the radius. Here you can see head of the ulna and ulnar notch of the radius. Capsule encloses the joint, but it is deficient here superiorly. And ligament, there are weak anterior and posterior ligament which strengthen the joint. Articular disc is triangular fibrocartilage that separate the cavity of the distal radioulnar joint from the cavity of the wrist joint, and it is uniting the radius and ulna. Synovial membrane lining the capsule, and nerve supply consists of anterior interosseous and deep branch of radial nerve. Movement allowed are supination and pronation. So here is the supination and pronation at the distal radioulnar joint. And the last one is wrist joint. It is condylite type of, here you can see synovial joint. It is present between the distal end of the radius. Okay, you can see here distal end of the radius and articular disc above. Here you can see the scaphoid, lunate and triquetral bone below. So this is the joint between the radius and the proximal carpal bones, including the scaphoid, lunate and triquetral. So it is also known as a radiocarpal joint. The capsule encloses the joint and it is attached to the distal end of radius and ulnar below to the proximal row of the carpal bones. Ligament, here are anterior and posterior ligament which are strengthening the capsule. Medially it is attached to the styloid process of ulna and to the triquetral bone, and the laterally they are attached to the styloid process of radius and scaphoid. So these are the attachment of anterior and posterior ligament of the radiocarpal joint. Synovial membrane lines the capsule and attached to the margin of the articular surface. Remember, the joint cavity does not communicate with that of the distal radioulnar joint or with the joint cavity of the intercarpal joint. So here is the joint cavity of the radiocarpal joint. It is not communicating here with the distal radioulnar joint, and also it is not communicating with the intercarpal joint. Nerve supply is by anterior interosseous and deep branch of radial nerve. The movement allowed here are adduction, abduction, flexion, extension and circumduction. Rotation of the wrist joint is impossible because the articular surface are ellipsoid in shape. However, pronation and supination of the hand compensate for the absence of this movement. So all these are the movement which are allowed here at radiocarpal joint. Applied anatomy, there is Colles fracture. So this is fracture of the distal radius metaphyseal region with the dorsal angulation. So you can see here fracture at the distal end of the distal end of the radius, and there is a dorsal angulation. Mechanism or cause of injury can be fall on outstretched hand, and risk factor highly prevalent in older adult and individual with the reduced bone density, such as those with the osteoporosis. Symptom can be immediate severe pain, swelling, bruising, and there is upward bending of the wrist. So you can see here, this is the Colles fracture. You can see here, this is also Colles fracture. So these are the references, and thank you.